Before we dive in, a quick note. We are brand new to this and we're still figuring out our equipment. So the audio quality on these first few episodes may not be perfect. We appreciate your patience while we work out the kinks, and we promise we will get better. Hey everyone, quick note before we get into it. The dark side of healthcare runs a little differently than what you're used to from behind the business of healthcare. No B roll, this is pure audio, more podcast than YouTube video. So if you're watching, feel free to minimize the screen, pop your earbuds in, go for a walk, fold your laundry, clean your house, whatever works for you. Just listen. The content is what matters here, and it hits differently when you let it. If you're wondering how a healthcare business channel ends up with a true crime series, here's the honest answer. I came into healthcare with 2 degrees, a bachelor's in criminal justice and a master's in business administration with an emphasis in healthcare administration. I didn't choose those 2 fields by accident. I've always believed that understanding how systems are supposed to work is inseparable from understanding how they get corrupted. The dark side of healthcare is where those 2 degrees finally get to work together. So, welcome to the dark side of healthcare. I'm Heather Skousen, and joining me is my co-host for the series, Dena Diamond. You can say hello, Dena.
Hello there.
Hello. Dena has spent 19 years as an insurance and prior authorization specialist, most of the time in interventional radiology, and I can tell you firsthand that those 19 years are the real thing because I was there for them. Dena and I worked together in interventional radiology for her entire career in that specialty. I was her boss. I watched her fight those fights from across the hallway. I saw what the prior authorization machine does to people who have to work inside it every single day, and I saw what it does to the patients on the other end of those denials. There is nobody I would rather have in this conversation with me. So, Dena, welcome back.
Thank you. I'm glad to be back.
All right. So, if you heard episode 4 of Behind the Business of Healthcare, you already know her voice. If you didn't, you can go back and listen because that is where she laid out the foundation of everything that we're going to talk about in this episode. And joining us for this is Holly.
Hey!
She's our true crime enthusiast. She has the typical experience of healthcare as a patient and caregiver from aging parents. As we share with you our case studies, she will be giving her raw and authentic responses of what happens on the dark side of healthcare. This is a spinoff of Behind the Business of Healthcare. Same channel, same commitment to telling you what's actually happening inside this industry, just with the lights turned all the way up on the parts that most people would rather you didn't see. All right, are we ready, you two?
Ready.
I'm ready.
Okay, let's get into it. In 2023, a physician at a major health system spent 43% of her clinical week not seeing patients.
Wait. What was that percentage?
It was 43%.
So almost half of her time was not
Yeah.
with patients?
Yeah, almost half of her time was not with patients. Are you wondering what she was doing?
Well, I was paying her something, that's for sure.
Were you or were your insurance? Was your insurance? I don't know.
Same thing.
Same Dena's like, same thing. Yes, I shouldn't have said that. Okay. Not seeing patients in the clinic, not in the operating room, and not at the patient's bedside. She wasn't even charting. What she was doing is she was fighting insurance companies. Okay. The insurance companies waiting on hold to do peer-to-peers and redocumenting clinical, not because it was wrong to start with, but because what was already there just needed to be bolded and made more visible for the insurance to recognize.
So wait a minute. We're already setting this up that we need an Aaron Brockovich to get in there and really solve these problems?
Yes, I mean, Dena was supposed to take on being Aaron Brockovich in my life, and she was going to go and take on the insurance, but I don't know. What happened, Dena?
I don't know what happened, but I better start. I better watch it again. I'm not sure if too many young people will even know who Aaron
I was going to
Brockovich.
say, those of you listening, we are a little bit older in this group, so we maybe will reference movies that you might not know, but they are well worth the watch. So, Julia Roberts, everybody, like, great actress.
And she went and took on the big business.
She did. She took on the big business, and in this case, it would be the insurance, is what you're saying.
Yep.
Yeah. Okay. And in most of those cases, she was winning all of those. So all of the stuff that she had to do to make something more visible for the insurance, they were turning around and winning them, which means the care was actually medically necessary. The insurance company, on some level, knew it was medically necessary, but they said no anyways. Okay. So that is not a broken system, though. That is the system working exactly as it's designed to. I do have to give everybody a heads up. We do have two adorable dogs in this household, and they like to have their voices heard as well. So you may hear some barking. They're just enjoying the neighbors. So, okay. So what we need to do is we need to start with what prior authorization was supposed to be. Because before we can dismantle the system, I want to give prior authorization its one fair moment. Because context makes the story darker. The original premise going back into the 1980s and 90s.
We kind of recognize those dates, don't we?
Yeah, I mean we were definitely around for those dates. So back in the 90s and the 80s, like the actual prior authorization premise was defensible. There was real overutilization happening. Procedures being ordered that weren't always clinically necessary. A pre-approval checkpoint made sense because let's confirm if the care is actually appropriate before we pay for it. Totally can get on board with that. But somewhere between that reasonable original premise and today, prior authorization stopped being a clinical tool and it became a financial strategy.
Well, the math is simple. Every authorization you delay or deny, even if it's temporary, saves the payer money. And if even a fraction of patients or providers give up and don't appeal, that's pure margin. No clinical review required, no accountability, just a denial letter and a countdown clock.
Okay, so here's where the numbers land then with that, right? The American Medical Association surveys physicians on this every year. Physicians submit an average of 45 prior authorization requests per week. 94% of
Wait,
the,
okay, wait. I'm sorry to interrupt you, but
you're okay. That's what you're here to do.
45 pre-auths a week?
Yeah, so
So in
45,
just one provider.
one provider.
So if a clinic has 5 providers, they're doing 5 times that in a
that would be
week.
correct because this is per physician
Okay.
per week. Okay. 94% report that prior auth caused delays in care. And 1 in 4 physicians, that's 1 in 4
Wait a minute.
physicians.
Wait, back up. 94% report that it
causes
a delay.
A delay. It causes a delay in a patient's care.
Well-
Like, let's be honest, prior authorizations are causing delays in almost every patient's care.
I was gonna say, when
So-
you look at 94%, that's only 6% get approved. So that meaning the doctor can
Just
act
act
immediately.
Yeah, exactly. So 1 in 4, though, say that prior auth was directly led to a serious adverse event for a patient in their practice. Do you know what an adverse event is, Holly?
Oh, a serious injury or death.
It's where a patient got hurt,
Yeah.
right?
When there should probably be no reason for a prior authorization in the
In
first
the first place. Exactly. So it's frustrating. It's frustrating that's even happening.
And this connects to what we broke down in episode 4 of Behind the Business of Healthcare, the investigational denial, which is one of the most infuriating tactics in the entire payer playbook. To know more about what this is, you will want to go back and listen to the interview for prior auth and predetermination. But with an investigational denial, the patient suffers more and the payer sometimes ends up paying more, but the denial still happens. So what are IR denial rates among the highest in Medicare? If it really is about cost containment, because of cost containment, we never really,
It was never the point, right?
no, it wasn't the point. Delay is the point. Friction is the point. Betting that enough providers and patients will give up before the appeal clears. That's the point. When you understand that, the math stops being confusing and starts being infuriating.
Yeah, the math ain't mathin'.
Math ain't mathin'.
But okay, you say I'm going to not be confused and I'm going to be infuriated. I think I'm mixed up in those two emotions because
Are you confused and infuriated right now?
That
Yes.
makes sense.
Well, but I guess where I'm confused is sometimes some of those delays, don't they create bigger issues, just like we said, an adverse
Mhm.
issue
Yeah.
that's going to cost the insurance more in the end?
Yeah, that's the problem that we would often see with IR denials. Like we really honestly cannot understand why we get IR denials so much because the whole concept, I mean, I don't know if a lot of people who are listening understand what interventional radiology does, but they do less invasive procedures on patients so that they're not going in and having procedures where they're getting cut open and they're going to have a much harder recovery, and all those things. Sorry, guys, about the dogs. But what's happening is that those prior auths are getting denied, and then the patients are going in for a surgery that costs the insurance a lot more money than what the interventional procedure was going to be. The patient takes a lot longer to recover from it. And so we're like, is this really about the money? But it's kind of what Dena pointed about
Right.
earlier, is that they're hoping that that original denial is going to just stop the clock
Yeah.
completely. That's where it's going to save the insurance money.
So in the end, the math isn't mathing for us, or we don't understand, but their end game must show
Must show.
that it works.
Well, and I'm guessing that a lot of people just give up because of that infuriation and the confusion.
And that's their goal. That is literally their goal. We have heard from insurance representatives have literally told us that they have been instructed at the end of the day, if they didn't get to a prior auth, that they are just supposed to get rid of everything that was on their desk so that it just starts the clock all over again. Now, granted, that was a lot of years ago when we heard that, and I don't think that's happening now because everything is digital now. So there's so many things that are not even in paper on somebody's desk. It's just now in a queue on the computer. But that's what employees who worked for insurance companies were being told, is that if you didn't get to this at the end of the day, it goes in the shredder bin.
Yeah, I remember those days.
Yeah, right?
Wow.
Yeah, things you didn't know, that it's like we're totally switching the lights all the way
That's
up
right.
for
The
you.
lights are turned on bright.
Yep, they are. Denials that have nothing to do with clinical reality brings me to something most people outside of healthcare have no idea that's happening. We've always known prior auth denials could be wrong, that a reviewer might misread the clinical, apply the wrong criteria, or simply not understand the specialty. That is bad enough. But what we've learned in the past few years is that from some of the largest payers in the country, the denial isn't even coming through a human. It's coming from an algorithm. Dena did touch on this a little bit on our episode, our fourth episode that we did of Behind the Business. But here is the validation of the concern that she brought up in that episode. In 2023, a major investigation revealed that United Healthcare was using an AI model called NH Predict to automatically deny claims for post-acute care, skilled nursing rehabilitation, the care that elderly patients need after hospitalization.
Okay, wait
The
a minute. Wait. It was
Yeah.
automatically denying.
It was automatically denying 90%. I hadn't even got to that number yet.
Oh,
So
wow,
now you're kind of like, what? Okay.
Yeah.
So yeah, the algorithm had a 90% denial rate. Okay. And internal data showed that it was wrong roughly 1 in 4 times.
We're talking about the most vulnerable population of elderly and like the need skilled nursing.
Yeah.
Like you said, skilled nursing,
Post-acute
rehabilitation,
care. Yeah.
elderly.
And the ones also who are less equipped to fight.
Yeah, because they don't know how to fight it. Right? So whistleblowers came forward, former employees of Navi Health, the subsidiary running the model, who said they were told explicitly, follow the algorithm when your clinical judgment says otherwise, even when the treating physician says otherwise.
Okay, this sounds a lot like A Few Good Men. Just do
You are
what
hilarious. You are going to reference all these movies.
but just do
Another
what,
old movie
yes,
too.
do what your commanding officer tells you to do.
Yeah. And apparently people
Well, at least
can't
you're
handle the
giving
truth.
great movie recommendations.
Yeah. People, if you get anything out of this, all these episodes, you at least are going to get some good movie recommendations.
Well, old movie recommendations.
Yeah.
Good.
Yeah.
You're introducing people to some classics.
Yeah.
There we go. The lawsuits allege United Healthcare knew the model was producing errors at scale, knew that real elderly post-surgical patients were being sent home or had lower levels of care before they were medically stable. And they kept running it. That's the thing, is that the insurance kept running the algorithm because the denials were profitable for them. Okay. United Healthcare is not alone, though, on this, because Cigna's story is somehow even more brazen. In 2023, same year as the other one, the ProPublica published an investigation based on internal Cigna data and former employee accounts. What they found was that Cigna's medical reviewers were rejecting claims without even opening the patient file.
Does that make sense? Makes
So,
sense.
Does
my claim goes through, and they just basically toss it in the garbage and say, "Nope,
denied.
denied."
Denied. But I mean,
But we
first,
don't even look at it.
but first, we got to check a box that says
Yes.
denied. So, okay. And I'm going to repeat this though, because we are going to point this out that they're not opening the file, and the reviewers are processing these unopened but claiming they've been opened files
Why are
within
you doing quote marks?
because they're claiming
This is
I
this
know,
is a
but nobody can see
podcast.
me.
Nobody can see you.
Sorry, guys. I was doing air quotes for the people I'm talking to. But they were processing those denials in 1.2 seconds. Okay. It took me longer to say 1.2 seconds than it actually took for them to turn around and deny a case. Okay.
It took you longer to do your air quotes
I know
too.
it took me longer to do my air quotes. It took you longer to make fun of me for doing those air quotes. So, in 1.2 seconds, those cases were supposedly reviewed. And in that time, Cigna physician was supposedly reviewing patient records, clinic notes, treating physician justification, and making medically sound coverage determination.
So is this a physician's issue or is this a insurance issue?
This is an insurance issue. This is not a physician issue. This is an insurance who has instructed their people, whether it's their physicians who work for them, their nurses who work for them, their case
Customer
reviewers, they are instructing them to automatically just deny. And the thing is that it's still algorithms that are finding this. The difference that happened with Cigna that was different than what happened with United Healthcare is that Cigna turned around and claimed, though, that their denials were provider reviewed. So therefore, they felt that it was still justified. However, it was an algorithm that sent the list to the doctor to checkbox it to be denied.
In
Huh.
1.2 seconds. That's speed reading.
Yeah, that is speed reading right there. Holy cow.
Well, you've seen doctors' handwriting. You can't read it anyway.
That is true. That is true. So, okay. Former employees described internal quotas, targets for cases processed per hour, a culture where slowing down to actually read a chart was discouraged. Cigna denied any wrongdoing. This is where I was telling you that they felt like that they were doing what was right, which is having a physician review the clinical. But they did stop doing what they were doing. But the problem is that the outcome was undone for those who had already been denied.
Let's step back from the corporate story for a moment.
Okay.
Because it's easy to get absorbed in algorithms and class action suits and lose sight of what it's actually about. Prior authorization delays can cause patient harm. That's not rhetoric. That is documented in peer-reviewed research. The Journal of American Medical Association has published studies showing prior auth delays correlate with worse clinical outcomes, particularly in oncology, cardiology, and interventional procedures. Patients' treatments are delayed weeks while an insurance company decides whether the procedure their specialist ordered is medically necessary.
So we're talking about a heart patient. Just take another couple of aspirin for a couple of weeks because the insurance is denying you in 1.2 seconds.
Yeah, or it could sit on their desk for a little while and then get denied. Yeah,
Yeah.
exactly.
Yeah.
The specialists being second guessed by reviewers who frequently are not specialists in the fields they are reviewing.
I mean, yeah, Dena kind of went into that I know that you weren't part of that episode, so you
But
could go
I
back and
listened and
listen. Yeah,
watched.
okay. But she went into that where she talked about the physicians who are reviewing this at the insurance level are not even the same specialists. They don't know the same specialty as
no.
the procedure is being done.
No, they would need to do some studying actually most of the time. And in interventional radiology, this has a specific texture. A patient who would be having an IR procedure and they get denied doesn't just wait. They either go without care, like we talked about earlier, or they end up in a more invasive surgery that costs the system more and costs the patient more in recovery time and risk.
So I want to make this personal for a moment because this isn't abstract for me or Holly. About 5 or 6 years ago, my mom had a serious fall at home. She already had a broken foot and was using a knee scooter to get around. We still don't fully understand what happened, and she honestly doesn't remember it either, but we think the front wheel of the scooter caught the top stair and that she fell down an entire flight of stairs. Well, we know she fell down the entire flight of wooden
Yeah.
stairs. We just don't know how it
Yeah.
happened. So she was life flighted to the nearest trauma center that night. Serious brain injury, broken bones, internal bleeding. We were told to prepare for the worst. She spent weeks in the ICU. She had a tension pneumothorax, which, if people don't know what that is, it's where your lungs collapse and they push against your heart. She had complications on top of complications, and then slowly she started to improve. When she was finally ready to be discharged, the team told us that she would need to go to a specialty hospital or a skilled nursing facility. She wasn't going home. She wasn't even close to going home.
She had other ideas, but no, she wasn't
Yeah,
going
I
home.
mean, yeah, that's true. As she has a tube still sticking out of her mouth, she's telling us that she's going home.
There's no place like home.
That's true.
And she did do record time, but
She did.
But
They
still,
said that she was
was not-
recovering
yeah.
well, very well. But she wasn't even walking.
Is this
Like-
where people are learning Holly's your sister?
Yeah. Oh, that's okay. So
oh, probably.
Holly and I are related. Holly is my sister. Holly is my older sister.
Heather's my younger sister.
So there we go.
The very supportive
and Dena
sister.
is part of the family as well. Just she's kind of like a sister from another mother
Right.
sister.
Adopted.
Yeah, there we go. So there we go. But the one thing that we had going for us is that her insurance wasn't using the algorithms that were denying that care. So I am aware in ways that I wasn't before we started doing this work, that exactly how fortunate that we were that she didn't have one of those insurances, because the system I started to describe to you, that algorithm, it was going when mom was in the hospital.
Well, and that's what I'm sitting here thinking about. If mom would have been denied, what would we have done?
I have no idea, because there's no way that we could have taken care of her
No.
and we wouldn't have had the money to pay for it ourselves.
No, right.
I know
And-
dad would have gone bankrupt to take
And
care
most
of that.
family members would.
Exactly.
That's the thing and the companies know that. The companies know that when we're talking about a loved one and their life of that loved one, people are going to do everything they can to be the support that they need.
It'd be the support they need.
Exactly.
Yeah. So here's what I want every person listening to take from this part of our conversation. If you or someone you love is ever in that situation and the insurance says no, that is not the final answer. Most patients don't know that. Most families, in the worst moments of their lives, they're exhausted, they're terrified. They take that denial letter and they take it as the end of the road.
But that's what we're always told. So I don't understand. Like,
That's
we're
because
told
they
that our
don't have
insurance-
they don't have somebody like you, like they don't have like you. They don't have someone like you who has somebody in their corner like me who knows that that's not okay, or Dena
Right.
who knows that's not okay. Most people don't know that that's not okay, so that's why we want them on this channel to hear that you have rights.
You have
can
a
fight.
voice. Pick up the phone.
Yep, exactly.
Start fighting.
Start fighting. Don't take it. It's not the end of the road. You can appeal this. You can fight it. There's more often than not that these actually turn over. Like, so if it's denied and it's medically necessary, they can be overturned. And a lot of people are winning them, but people don't know that. So they're not doing that.
So are you going to tell us what we need to know to do that?
Well, okay. I mean, we can. It's not part of the script here, but you can go to the behind the business of healthcare, because we do explain how you go through that process on behind the business of healthcare. But really quick and to the point is you call the insurance, you call your doctor's office. If they're not going to, if it's not going to get escalated, if you have Medicare Advantage, you have a right to do a completely independent review and have that reviewed. And there's a process that you can go through with that to have
It's
that
just
done.
getting through.
Yep.
Calling, maybe once will work, but calling is what's going to help.
Okay.
Yeah. So thank you for asking that. I think the cultural moment that made all of this impossible to ignore, though, because the things that we're talking about are things that people don't really know about or understand, right? But what brought this to the forefront was in December of 2024. And I think we all remember this. Public anger towards insurers reached a level that culminated in a tragic act of violence. Brian Thompson, the CEO of United Healthcare, was shot and killed outside of a hotel in Manhattan. I am not going to dwell on the act itself. A man lost his life. A family lost someone. That is real and it matters. But what happened in the days that followed on social media was something I don't think any of us expected. Instead of the universal grief and condemnation you might expect after a public figure's death, there was rage from ordinary people. People were sharing their denied claims, people describing watching family members fight for care that was deemed not medically necessary by someone who never examined them, people who had spent years drowning in medical debt for care their insurance was supposed to cover. That alleged shooter left behind writings that directly referenced a strategy called delay, deny, defend. The social media response suggested that many people felt that they had been living inside that strategy for years without ever knowing it had a name. So we're going to give it the name. We're going to explain to you what each of these mean.
Delay is the first weapon. Payers intentionally stall the claims process, burying providers in redundant paperwork requests, leaving peer-to-peer calls unreturned, slow walking payments for weeks or months beyond what any reasonable reviewer should require. Every day of delay is a day the provider has not been paid. Every week of delay is a week a patient is waiting for care. And every delay is a calculation. How many of these will go away if we wait long enough?
It's a waiting game, right? So deny is the second one. Claims and prior authorizations are rejected outright. Sometimes as we've documented on this episode, without a proper clinical review, without opening the file, without a physician who understands the specialty making the determination, the denial letter arrives and it looks final. It looks official. It looks like it's the end of the road. It is designed to look that way.
Defend is the third. And this is where most people get nervous, is when the patient or provider refuses to accept the denial and pushes back hard enough, when they appeal, when they threaten legal action, when they actually file a lawsuit. Who has the biggest dollars, the
I can
biggest
tell you, we
lawyers?
couldn't fight against an insurance.
Yep.
Yeah.
So it turns into long litigation, drawn out trials, legal fees that accumulate faster than most patients or small practices can sustain. The financial burden of fighting becomes so unbearable that most people settle for less than they are owed or
Give up.
give up.
So it sounds a little bit like a Jerry Maguire situation. Show me the money.
Oh my gosh.
There's another one.
Wow. And it's even another old one, guys.
Yep, still
Holly,
goody.
Holly, we kind of don't share our age on this podcast, but
We're
think
not going to.
I think you're aging us.
We already referenced to the 80s and 90s.
That is true. That is true. All right. Well, okay, there it is, guys. It's delay, deny, defend. 3 stages, 1 strategy. And the strategy works because all 3 phases share the same design principle. Make it so exhausting, so expensive, and so demoralizing to fight back that most people don't. What the social media response to Brian Thompson's death revealed, and I say this not to justify anything, but to diagnose something, was that millions of people have been living inside this strategy for years without the vocabulary to describe it. They knew something was wrong. They had felt it personally, but they didn't know it had a name. That moment gave it a name. And the conversation that followed, however uncomfortable, is exactly why this series exists. Because the answer to systemic healthcare corruption is not violence. It is awareness. It is knowledge. It is knowing that delay, deny, defend is a documented, deliberate business strategy, not an administrative inconvenience. And it is enough people understanding how this machine works that it becomes impossible to keep running in the dark.
Regulators have not been completely asleep on this, and rational honesty requires acknowledging that. In January 2024, CMS finalized a significant prior authorization rule. It requires payers to respond to urgent prior auth requests within 72 hours and routine requests within 7 days.
So that kind of answered your question, Holly, when you're like, well, what if there's something that's urgent?
Right.
But it's still, they have 72 hours still to do it.
Yeah. A heart attack could have happened, but
Or someone's laying in pain.
In pain. Yeah, it's mostly that it's in pain. Obviously, like if you're having a heart attack, you're
It's an
going through the
emergency.
ER. But yeah, most of the time these patients are laying in pain.
So now they need to require payers to give specific clinical reasons for every denial, not just not medically necessary. Do your air quotes, Heather.
I'm not allowed to.
And it requires public reporting of approval and denial rates. That is meaningful. I don't want to dismiss it. But the rule applies to Medicare Advantage, Medicaid, and CHIP. It
Yeah.
does not fully apply to commercial insurance. And let's think about it. That's
That's what the most of the
the
people
working
have.
age of
Yeah.
Americans.
So what you're telling me that that law, because I am of working age and I have a commercial insurance, does not apply to me. So my case can be pushed aside while we're figuring out these 72 hours and 7
Or
days
7 days or 15.
or not even worried about it because it could be falling under
Right.
other
Yeah.
AI
Well, and they can
generated
also and
formulas.
they can still give you the denial of not medically necessary. They don't have to
Right.
tell you the details as to why it's not medically necessary.
Yeah.
So they can leave it as vague as they want.
Wow.
So
Which then you can't define the issue, fix the clinical, put it in the
yeah.
clinical. It's just not medically necessary.
So and
And once again, going back to, it's not always a person who actually knows
how to do it,
how to
how to fight
treat
it.
this.
Oh yeah, exactly. Oh yeah, like you're right. It goes back to that. It's somebody who is making this decision at the insurance level that doesn't even know that much about the procedure being requested.
Right.
So
And is this, because I see this type of thing with medications a lot too. Is this in that same category? Are
where
medications?
medications get denied? Is that what
Yeah.
you're talking about? Well, on a lot of times on medications, yes and no, but a lot of times they're wanting you to take a generic.
Yeah, they just want you to switch from the name brand, so
Yeah.
to speak, to a generic.
So they're doing that to get you to get them to save money, but there's usually another option like a generic.
Generic. Okay.
Yeah. Yeah. So good question. And the deeper problem, disclosure doesn't stop bad behavior. So just because it's visible doesn't mean that it's going to stop the denial rates. It just means that they're going to say, yeah, we have a 90% denial rate. And there it is.
Do insurances like to have high? I mean, I know that they like to have high denial rates, but is that kind of like a badge of honor to say, I have
I don't think so.
90%?
I don't think so. Honestly, I don't think it's a badge of honor. And I truly believe that they don't want to be running at a 90% denial rate because I think that what happens is that insurance companies still rely on employers to choose their insurance for their employees. They rely on um, if they're in the marketplace, they rely on those people picking their insurance, but a lot of times they're relying on employers, to
And
choose their insurance company to give to their employees. So they don't want that actually announced, even though in the long run, it's not going to change how they do business.
and we do have to remember, and totally different subject, but premiums are also running how
We
our
could do a
employers
whole
are
nother,
picking.
yeah,
Yeah,
we
we
could do a whole
could.
nother episode on premiums. Yeah, exactly. So, I mean, it just tells you that the insurance is making a lot of money on the front end with the premiums and they're saving a lot of money on these denials. So, somebody's getting,
Show me the
yeah, somebody's getting
money.
richer. Somebody's getting richer and it's not the patients. We've also seen state level movement. Several states have passed what are called gold carding laws, which exempt physicians with strong approval track records from prior auth requirements for certain services. Early data suggests it reduces administrative burden without increasing utilization, which tells you something important. A lot of prior auth was never about clinical appropriateness to begin with.
So, okay, so let me break that down. Really, what it is if a doctor has proven their validity over and over and over again, then they may be put in a situation where they don't have to go through a pre-authorization process to do the procedure or process for the
They just
student
get automatic
patient.
approvals.
A lot of work on the front end, but we were able to take advantage of that with one insurance
Yeah.
for a while. And it was really nice just to make sure everything from their policy was in your clinical, review
That's
it
true.
prior. It was an automatic
It
authorization.
was nice. It made Dina's workload reduce significantly because of the fact that she knew she was going to get these approvals just automatically. So,
Super nice.
okay. So if you're listening as a healthcare operator, practice administrator, health system leader, clinic owner, revenue cycle director, here is what I want you to take from this episode. This is not abstract. This affects your revenue cycle, your clinical staff's burnout, and your patient's outcomes all simultaneously. Your denial data tells a story. If you're not tracking prior auth denial rates by payer, by procedure, or by service line, you are flying blind. You need to know which payers you're denying disproportionately because not all payers behave the same way, and some are systematically gaming the system. Guys, if you guys are watching this in the morning, we're doing this in the evening. So we're struggling here. Your appeal win rate is evidence. If you are winning 60 to 80% of your prior auth appeals, that is documented proof that the original denials were wrong. Save that data. It matters in contract negotiations. It matters if you file a regulatory complaint. It matters if litigation ever becomes relevant.
Well, and even more important than that, it matters for the patient.
Yeah.
And that is our final goal, right? That's why we're in the
Why we're here.
business, is
It's
for the patient.
for the patient.
Mhm. Even though they're kind of scary and daunting, peer-to-peer requests are underutilized, but they have to be done right. The approval rate on a peer-to-peer significantly exceeds standard appeals in most cases. But as we have shown you today, a peer-to-peer is only as good as the reviewer on the other end of the line. Build strategy into that process, including knowing when to escalate and when to hang up and call back.
And document everything.
Wait a minute. Hang up and call back? What do you mean by that?
That is Dena's go, man. There are so many times I'm looking at her and I'm just watching her and I'm seeing her getting frustrated across the hall and all of a sudden, click.
Well, yeah, in the end, should I waste my time anymore even trying to end the call if I'm not getting someone on the line that is going to listen, look at the clinical with me, try to escalate the situation to the top, get a peer-to-peer review? I may as well hang up and start again.
Oh. Hopefully, cross your fingers, you get a different person answering the phone.
That's really what she does.
Yeah. With the bigger insurance companies, you're almost guaranteed it. I think there has been a time or two, though, that it was the same person. Just hang up again.
You're just rolling the dice. All right. If a patient is harmed because a prior auth was denied or delayed, that clinical record is a legal record. The denial, the timeline, the clinical impact, your team's response, all of it. It protects the patient. As we just talked about, this is why we're here, is for the patient. It protects the organization. It also creates the evidentiary trail that regulators and attorneys need when they have to hold payers accountable.
Do they get held accountable though?
Well, we do have, some upcoming episodes where we're going to talk about some of the litigation that has gone through with some of these payers, and they've had to pay some huge fines that, they're mind-boggling to me. They might be a drop in the bucket to the insurance company, but the level that they've had to pay with what they've lost in these litigation suits, it's mind-boggling.
Holly, stay tuned.
Yeah.
I'm on the edge of my seat.
You're going to have to join us next time so that you actually get the answer to that. So prior authorization was sold as a clinical safeguard. What we've documented today, algorithms with 90% denial rates, physician reviews lasting 1.2 seconds, peer-to-peer calls designed to end in no, regardless of the clinical evidence, and the 3-phase strategy called delay, deny, defend that is built from the ground up to make you give up. That is not a safeguard. That is a business model. Dena has spent years fighting it every single day. Yeah, she's doing some power arms here. And the fact that the fight is still so hard 19 years in tells you everything you need to know about how entrenched this is in the system and how much it would cost people running it to change. The social media rage that followed on December 2024 wasn't really about one man or one company. It was years of frustration. It was the family in the ICU waiting room not knowing that they could fight a denial. It was the physician spending 43% of her week not with patients but on hold. And it was millions of people finally having a moment to point and say, that's what's been happening to me. The answer is awareness. It is knowledge. It's this conversation. If this episode connected with something you've seen in your own organization, in your own personal life, or in the loved ones, we want to hear about it. Drop it in the comments. Subscribe to Behind the Business of Healthcare to get more information on the definitions, the policies, and the protocols that we talked about here today. But don't forget to subscribe to the Dark Side of Healthcare so that you don't miss the next episode. So Holly, Dena, thank you. That was our first episode down.
Woohoo!
Yay.
Yay.
Thank you. Until next time.
Until next time, because there's always more.
Bye.
Bye.
Bye-bye.
Thank you for listening to The Dark Side of Healthcare, presented by Behind the Business of Healthcare.